get started on giving you some information for the board review for AANP and go over some information starting with the GI. So, just kind of, starting with appendicitis. Remember the location of your organs. No, you will not have to know this for boards, but you do need to make yourself aware of where the information is. So, for example, you need to know, you know, where McBurney's point is for sure. That was something that is highly tested over. Is McBurney's point, in the left lower quadrant? Well, if there's a question on boards, referring to McBurney's point and say you chose left lower quadrant because that's where you think the appendix is, you would get that wrong. So the location may help you direct to a possible diagnosis or even a list of differentials. Abdominal pain can be referred to other places, as we know. It can be referred to the back. It can be referred to the epigastric region. It just all depends. It's very finicky. So if you kind of know the gist of where, what the question is asking in terms of the pain and location, you should be good. So this is just something I made as far as that had helped me when studying for boards. Because like I said on the cranial nerves video, I found a different way. I learned a different way, I guess, to study for boards. And so for appendicitis, for example, signs and symptoms. So you will definitely have some involuntary guarding that would, signify, like your appendix is about to rupture. So I have a man involuntary guarding or just guarding. So that's a way to remember, be able to recall that information when you're testing, because it's all about recall. If you can, picture in your head a man guarding, involuntarily guarding something, you definitely, would be able to pick that out on a question. Also, you're going to have that rebound tenderness, which signifies again, if you need like a basketball symbol or you see a man like a chef, hammering down on the abdomen as if he was tenderizing something. Again, that's going to help you as far as recall. Of course, you're going to have that, right lower quadrant pain. You're also going to have the term McBurney's point tenderness during palpation. And so in the top right, you'll see where McBurney's point is located. So, this is, of course, the patient's right side. So you need to just kind of know the location of where this point is, because it's going to be very important, on boards. Also, the Markle sign. And, I have a picture of Meghan Markle here just to kind of jog your brain when you're trying to recall. But as far as objectives with appendicitis, Markle sign is when a person hops on one foot. It will cause pain within that right lower quadrant. The Roseving sign also is something that you will need to know as far as boards goes. And the obturator sign, something that could help you remember is an operator, because it sounds similar to obturator. So again, it's all about the recall and knowing what to assess for. Also, you have a LL spaz sign, which is something else that is a part of appendicitis. So these are all objective findings that may help you when you take your boards. The boards may not list every single one of these signs, but they will for sure list a couple of these. So again, it just goes into detail exactly what they are. So again, the Markle sign is when a person hops on one foot. It can cause right lower quadrant pain. As far as the obturator sign, in acute appendicitis, if you place your hand over the patient's right thigh and they flex it at the hip and push down, it'll be positive. They'll feel that pain. And so we also have, as far as my studies goes, we had the Bates physical exam book. And they do give 3 different techniques to elicit a response. But again, the boards will not go into detail with that. I did that for my own personal understanding as far as, when I was studying for boards. Okay, a positive Rosevine sign, aka rebound tenderness, which that's what we know it by. But the boards may not say rebound tenderness. They may use the opposite word. So when you perform depalpation and say, withdraw your hand, the patient's going to feel that pain. And then also for the positive ileospasm testing, if the patient lies on their left side and then you hyperextend that leg, they're going to elicit pain on that right side. So again, it's just something, you may not have to remember all of this information, but you do want to pick out bits and pieces so that way you know that if the boards give you information as far as one of these, positive objective signs, you should be able to pull that out. And I can say for sure that a couple of these are for sure, going to be tested on for boards. And as far as appendicitis, in terms of, what you kind of want to pull out, because it is a lot of information in terms of GI, you definitely, acute appendicitis is less than 12 hours, 12 to 24-hour onset. You see it a lot in younger kids, but adults can get appendicitis too. You're going to have that nausea, vomiting, anorexia, meaning you're not going to want to eat. Periumbilical pain is kind of early on in the disease state. You're going to have that board-like abdomen, some rebound tenderness, that referred pain. That may be a late sign. Again, you're going to have some of those positive objective signs that I had on the previous slide. Of course, you're going to have some guarding because they're hurting. And also that McBurney point tenderness. I can't emphasize that enough, that you need to know what that is. And then of course the complication, everybody knows, if you've worked as a nurse on a floor, you don't want the appendix to rupture, or if they do come in ruptured, they have to go to the operating room right away. So this was just something, again, this was just kind of allowing myself to learn in a different way. I didn't need to rememorize this for the boards, but there was definitely some things in this, in this PowerPoint per se, on this image, that I did need to know for the boards. So, you can just take this. This was kind of fun way to kind of recall the information if you are one of those people who can use like songs or different mnemonics to learn what that is. So this is all about appendicitis. So it says, hello operator sign, I'm positive that appendix is ileospastic because she's involuntarily guarding her Rosevig nuts after Murphy, nausea, and vomited everywhere. McBurney pointed it out after she did a rebound and felt tenderness in her right lower gut. Imaging, if we didn't do a CBC before hothead, meaning they do develop a fever, leukocytosis, and that left shift showed up, girl, lap APPY would have got things all complicated and the whole thing would have ruptured everywhere. So if you're one of those people who, it sounds like a conversation, right? So if you're one of those people who need a jingle to remember things, that could be something you could use. And then we go into cholecystitis. Let's see. Just looking at my notes here. So we're going into cholecystitis, again, part of the GI. So this is just kind of like a recap of some patho. Again, if you need to know visually where these things are, of course, some people would say, oh my gosh, you're in NP school, you should automatically know exactly where these things are located. Well, yes and no. Sometimes we do, sometimes we don't. So if you do need like a small recap on visually where these things are, as far as the gallbladder, the pancreas, the appendix, stomach, liver, all that good stuff, here is that there. Just kind of like a recap. So as far as like, again, with the gallbladder, 30 minutes after eating, the gallbladder is going to contract, forcing bile into that common duct. So the contraction and all of that is something that you kind of want to put in your head, because again, when these boards ask you questions, it's going to be like, well, what causes those spastic contractions? Well, if you don't know that the gallbladder contracts after eating, then you might get the question wrong. Or if a question is making reference to what relaxes the lower esophageal sphincter, well, if you didn't know that the gallbladder can be relaxed, before after a meal, then you might not understand the question. So that's why I put kind of like a small patho, quickie on here so that you can just kind of, jog your memory. Because for me, for boards, I know what the gallbladder does and I know where it is, but I really forgot like the very small finite details of what actually goes about. So contraction of the gallbladder is mediated by cholinergic branches of the vagus nerve. The sympathetic nervous system can relax the gallbladder. So again, that word cholinergic, we see that all the time. Cholinergic meds, cholinergic side effects, all this other stuff. So those things can kind of help you recall that information for boards to say, oh my God, cholinergic. Okay, that's why, it causes this and this. So everything starts to piece together and work for the greater good so that you can recall that information. So that's why I put that on there. So risk factors for acute cholecystitis. Again, if you are good with the bright, colorful pictures, you're going to see, risk factors. Older age female, here we are here. Obesity, we got the lady in the swimsuit. Estrogen and oral contraceptives. Multiparity, the lady here with her kids and a pregnant belly, birth control pills here. Native American and Hispanic. Here we go with that, visual here. And then we have rapid weight loss. So that can kind of piece together for you some of the risk factors and kind of jogging your head if you need a visual, the colorful patterns. That is one of the things that helps us learn. As far as some classic acute subjective findings for cholecystitis, all of it in a nutshell here. You're going to have severe right upper quadrant pain or epigastric pain. So again, with the abdomen, when you learn in school, the abdomen is not a good storyteller. That's because with the abdomen, you can have different areas of pain. So, the gallbladder is on your right side. Well, why am I having epigastric pain, which is in the middle of your chest, if it's on that right side? Well, it can be referred. So again, if you need to go back to your physical assessment book, by all means do that so that you can picture in your head where the gallbladder is, and then you can start piecing together these objective and subjective findings. So, people usually experience this 30 minutes to 1 hour after eating. And then why is that? Well, because we saw on the previous slide that within 30 minutes of eating a, say high fatty meal, that gallbladder is going to start to contract, and it's going to cause, the cholinergic factors and the sphincter and all of that to work together, so that then if it is offending to your, say gallbladder, you're going to experience these symptoms. So you see how it all pieces together. That's exactly how the boards are going to test you on this information. They want you to know, they want to be able to assess whether or not you can piece together that information. So if a patient presents saying, every time I eat, say an hour after eat, I have this right upper quadrant pain, and sometimes my back hurts, sometimes my shoulder hurts, and, I get really nauseated, and sometimes I vomit. I don't want to eat afterwards. I've lost several pounds in the last couple of months. I want to find out what's going on with me. So if that was a question posed to you, in your head, you should be thinking weight loss, epigastric pain after they eat, pain radiating from their abdomen to their shoulder, nausea, vomiting. If the vital signs look good, you could say, okay, well, what if it's something going on with the gallbladder? What if it's something going on with the appendix? This is where the subjective and objective findings come into play. So again, objective findings. This is just a different way to look at it. You're going to have the positive Murphy sign, which is, Eddie Murphy here. When a patient takes a deep breath during palpation, the patient will experience pain and abruptly stop exhaling due to the pain. So, say you're assessing the patient on the table and you ask them to take a deep breath while you palpate. They're gonna experience pain if it's truly their gallbladder, and they're gonna not be able to hold their breath, so they're gonna blow that breath out. That's what the Murphy sign is. And so we have Murphy here, and then we have the sign. So Murphy plus sign. So that's a positive finding. We took Hoyer's course, so that's why Amelie's face is right here. So also the patient is going to have some right upper tenderness and abdominal rigidity. So here I have, ripped up abs. So you have a rigid abdomen. And then you're going to have some, tenderness there. Also, again, this is the gallbladder. So if you want to kind of piece it together, Murphy has some tender and rigid abdomen. And those are your objective findings in cholecystitis. So, if you're not a visual person and need all the little colorful pictures, you can kind of remember this mnemonic. Those are three things that will, pinpoint cholecystitis to you. I have a positive Murphy. Positive Murphy has some tender and rigid abdomen. It doesn't have to flow and make sense, but you do want to be sure you can pick that out. And then as far as treatment goes, as far as gallbladder, you do definitely need to know your gold standards. So gold standards for the, acute cholecystitic abdomen is ultrasound. Abdomen CT is good for if you think it's gangrene related or perforated. Of course, people are aware of the HIDA scan, that's good for obstructed duct. But if you see on the exam, if anything says gold standard, rule out cholecystitis, you need to choose your ultrasound. Why? Because ultrasound is cheap. Well, not cheap per se, but it's cheaper than a CT and a HIDA scan. It's quick. People are usually readily available to do the ultrasounds. You don't have to, withhold food, anything like that, if it's something that needs to be done right away. If it is, I'm sorry, if it is something where you think that the patient needs to have surgery, the surgery that they have is going to be a lap chole, and then they're going to have some rehydration, some antibiotics, and of course some GI rest, because anytime you have an abdominal surgery, you're going to need to kind of rest the gut a little bit and just kind of ease food back into it. Of course, lifestyle modifications, decrease or eliminate fatty meals. And of course, they do have medications for that if lap chole is not, where you need to go right away. So going into the pancreas. Let's see if I'm getting notes. So going into the pancreas, if you want to, depending on what kind of system you have, if you want to print this off and kind of write some notes, that'd be great. Again, I have the picture here of the abdomen, which, again, this is something, if you need a visual, print this out. I mean, that's what I did as well. And kind of write in where the organs are. So the liver is going to be, the liver is expensive. So that's why, again, when you have pancreatitis, or when somebody has pancreatitis, they experience epigastric pain. Well, why do they experience epigastric pain? Well, if you look on the slide, you see that the liver is located in the right upper quadrant region, but also in the epigastric region. So that's why people can experience those two types of pain. So that's, again, with recalling, visualizing and recalling that information, you can kind of say, oh, well, it might be the appendix. Well, if you looked at the previous slide and saw that McBurney's point is in that right iliac lower quadrant region, you wouldn't be screaming pancreas, because the pancreas and the appendix is not located in the same space. However, as you can see in the top right picture, that the gallbladder sits right kind of below the liver. So again, sometimes you have to be able to pick out those differentials. That's what it means by differentials. If I give you, several different things on an exam, will you be able to pick it out? It's not so much about memorizing the exact location or the exact symptoms. It's, jogging your brain. If a patient came in, how would you go about trying to assess what it is based on, where the organ is, what signs or symptoms are they having? So that's why I put these pictures up there for you guys. So again, I kind of put the visual up there so you can visually see where that pancreas, lies. Pancreatitis is caused by an increase and release of pancreatic enzymes. The enzymes cause irritation to internal mucosa, leading to some system toxicity. Infections such as mumps, certain metabolic disorders can cause pancreatitis. Drugs such as Lasix, Depakote, sulfa, or thiazides, they can cause pancreatitis. Of course, hint, hint, elevated triglyceride levels greater than, say 5 to 800 will definitely set you up for pancreatitis. That's something that is commonly, referred to on boards, the elevated triglyceride levels. And so, can pancreatitis be resolved? Absolutely. Just like with any organ, if you, follow the guide, of your provider, pancreatitis is something that can be resolved depending on what caused it and the severity of it. So objective findings to pancreatitis. So I put some real life pictures up here, but I also put some color pictures up here. So Cullen, Cullen from Twilight, I put that picture up here. So Cullen sign, and if that's something that somebody could remember versus a real life visual picture. So you're going to have the Cullen sign. That's going to be the bluish discoloration around the periumbilical area. And that is represented here as a real picture to visually, let you know what that looks like. And also the Turner sign, which is bluish discoloration around the flanks. Now this is, a little bit overkill, I guess, for something, that could be maybe caught early. I'm not sure. But it gives you a visual of what it actually looks like in real life. And it's blood. So that's definitely, both are positive signs that you will probably see on boards, and you need to be able to visualize it but also piece it together. So some labs and diagnostics for pancreatitis is going to be, they're going to see an elevated trypsin level, amylase, lipase, AST, and ALT. You're also going to have triglyceride levels greater than 800. So that's very important. You need to know that information on this slide. So some subjective findings of pancreatitis. Again, just because a patient's having this symptom, this looks pretty much like appendicitis and cholecystitis, really, because they're all in the abdomen. So you need to be able to kind of decipher and pick out those key words. The Cullen sign, the Graves Turner sign, the McBurney's point, the Markle sign. Visualize those pictures in your head and put those together with the disease. Just because somebody's having nausea, vomiting, fever, and pain in their abdomen, oh my gosh, that could be a list of things. So take the slides, take out the words or the findings that are objective and subjective, but put the ones that are objective with the disease, and be able to recall that information if it was in a question. That's the key. So some subjective findings again: nausea, vomiting, guarding, fever, abdominal pain that radiates to the mid-back, just like, the gallbladder, cholecystitis, abdominal pain that radiates to the right shoulder, shoulder back. A patient might, nobody in medicine a person that's not in medicine will be, I don't know, it just radiates to my back. Well, it could really be the shoulder and not the back. So just be able to visualize that and get out the keywords and stuff. So for example, a 47-year-old patient comes in with complaints of mild to moderate epigastric pain. Keyword, that's why I put it in caps. Past medical history, current alcoholic drinker. Right away you might say, oh, pancreatitis. Maybe not. Former smoker. On physical exam, you notice a bluish discoloration to the umbilical area. So that right there, that last part of that sentence, which again is something that, we're taught in school, is, the stem of the question. Again, I read some of the questions on boards 2 or 3 times. So just try to, read those questions, 2 or 3 times so that you can piece out what they're truly asking you. Of course, this is very generic. I just made this question up. So it's not going to be this easy. But if you kind of can put it together without having so much information and just a few keywords, knowing those objective findings, you will do fine. So what disease are you thinking of? What's indicative of this sign? So what disease am I thinking of? I'm thinking of pancreatitis. What's indicative of this sign? Well, it's indicative of hemorrhage. So what disease are you thinking of? Again, pancreatitis. What's indicative of the sign? This sign is called Cullen's sign. And then what does it represent? Intra-abdominal bleeding. So again, you being able to piece that information, you could have got that question right. So I'll be adding some more of GI, of course, because that's not all of GI. But I also will put something up that I did to help me for boards, which was kind of like a daily fill in the blank questionnaire form for myself. Yes, it was all about memorization, but with that memorization, especially with numbers as far as labs and, say triglycerides, things like that, it helped me piece together. So if my triglyceride level was 100, if that's all I had to base pancreatitis on, I would be betting no, it's not pancreatitis with a triglyceride level of 100. If I know that pancreatitis is at least 500 or more, then I for sure would pick pancreatitis. So some things do require memorization, but it's not those objective findings and things that you need to know as far as answering the question. They won't make it that simple for you. So again, I will put that up there as well so that you guys can have that as well too. So hopefully this video helped you. Leave me comments, critiques. Be more than happy to hear that information. Good luck, guys.